So we're going to embark on a slightly new endeavor now. We're going to present some cases, and I'm not trying to stump. I'm just trying to elicit different opinions. We'll certainly want to hear questions about the cases. We can actually have the questions after each individual case if there's anything more specific that wasn't covered by these cases. So case number one. Mr. B, okay, so this was, all right, so the automation didn't work, but Mrs. B is a 55-year-old woman with no significant medical history, diagnosed with CLL 5 years earlier. Her CLL has followed a slowly progressive course and now requires treatment because of anemia, hemoglobin equal to 10.2 grams per deciliter, and thrombocytopenia with a platelet count of 85,000 per microliter. Physical exam demonstrates mild cervical adenopathy, mild cervical and axillary adenopathy, and no splenomegaly. Her prognostic markers include CD38 being positive, ZAP70 positive, unmutated IGHV, and a deletion of 11q. NGS panel was significant only for a mutation of SF3B1. So I'd like to open up to the panel. Is there any additional information you require prior to making a treatment recommendation? Dr. Brown?
So I would probably get a CT scan in this patient, particularly because of the deletion 11q. Sometimes they do have central large adenopathy, which is something that I like to monitor during response or know about.
What about a bone marrow biopsy?
I do generally try to do those prior to treatment, mostly in case there are issues that develop during the treatment so that I have a comparison. But I don't always, and I don't really see, especially if you have a long history with this patient where you're seeing slow but steady development of the anemia and thrombocytopenia, it doesn't sound to me like this patient really absolutely needs one, but I do tend to do it unless there's a lot of objection.
Dr. K, additional information that you would want prior to making a treatment recommendation?
I think I agree with what Jennifer said. I usually do get a bone marrow biopsy, even if patients aren't going in clinical trials, more because I'm thinking that if I have a chance to get a complete response, I'd like to document what the bone marrow is initially. But other than that, I think I'd be happy with what's being done.
All right. Dr. Rai?
Whosoever created this patient
I don't know.
is very smart, because this sounds like a synthetic patient. Because relatively young age, seemingly without any clear-cut B symptoms, but evidence of slowly progressing disease, and all the markers which, if we used a knee-jerk reflex action, indicate therapeutic intervention. ZAP70 positive, unmutated, 38 positive, SF3B1 positive, and seemingly bulky disease with 11q deletion. So everything fits for a relatively younger age CLL patient, slowly moving to her death. But today, on the basis of these, would you have clear-cut indication for therapeutic intervention? If you did, you would fail in my book, because you are doing a knee-jerk reflex. This person should be closely watched, except that she will come to need some intervention. But would it be soon, like within a year or later, is unpredictable from this story.
So, Dr. Rai, what would serve your, or what would actually be your marker of the patient requiring therapy?
Well, the fact is that by not mentioning in this detailed report that she has 17p deletion or anything else, I would consider starting either ibrutinib one of these days or venetoclax obinutuzumab, but at this time I will continue to watch.
So what would be the change that you would look for that would prompt treatment initiation?
The woman starts to feel bad, night sweats, weight loss, infections, weakness, along with these symptoms.
Can I just say for the record, I did not recommend therapy.
We haven't gotten there yet, but okay.
I just want to say
Dr.
for the
Kay?
record, Dr.
Would you like
Rye
to
sitting
chime
right
in?
next to me, I did not recommend therapy.
So Dr. Davids, what are your thoughts?
I certainly agree with everything that's been said. In terms of getting additional information, I guess one thing that might help me would be to have some prior laboratory values so I could see what the chronicity is of the anemia and the platelet count. Have they sort of been in this range for a while and the patient's feeling okay, would make me feel a little more comfortable. If they've been steadily trending down, month by month, and the patient has these higher risk markers, doesn't have TP53 dysfunction, but has unmutated IGHV and 11q, then I might want to get some additional information to help me decide on treatment. So as Dr. Brown said, a CT scan in a patient like this might reveal really bulky lymphadenopathy and perhaps impending hydronephrosis or something like this. A bone marrow biopsy can give us a sense for how involved the marrow is. And if you have a very packed marrow and bulky nodes and higher risk markers in a patient who's minimally symptomatic, I might still move forward with treatment in that context.
So the bone marrow biopsy would impact upon your initiation of treatment?
It's one of the factors, I think, yeah.
Dr. Kay?
In the setting of cytopenias.
I agree. Those are really good points. I neglected to say, omitted, something that's very important, and that is that we need to rule out that she does not have some autoimmune cytopenia. And maybe that is something that you were looking for, and we should have said, and I apologize.
Wasn't looking for anything.
Oh, okay, never mind then.
All right. So the patient actually did have a progressively slow course, and based upon the historical counts, the bone marrow biopsy did confirm that this was likely non-immune-mediated cytopenias. So Dr. Davids, what would you be your current treatment recommendation?
So this is an area that's obviously evolved a lot in the last year to 2 years. And that a couple years ago, this is a patient I probably would have thought about FCR for. She's 55 years old and otherwise healthy and fit. So I think
Unmuted.
FCR is still a consideration, but I think in light of the data that we saw this morning from the ECOG 1912 study, we certainly would expect an improvement with an ibrutinib-based regimen. We don't know ibrutinib rituximab versus ibrutinib in the young population, but I think we can pretty safely extrapolate from the Alliance study that the rituximab is unlikely to add durability to this. So this is a patient where I think ibrutinib could be a great option, but I would also discuss venetoclax with obinutuzumab. Now, as you know, the CLL-14 study looked at comorbid patients who are typically a bit older, and so whether that data set completely applies here, not so sure, but I think particularly for young patients, the idea of time-limited therapy can be very appealing, and I have no reason to believe that the data in that older population or a comorbid population should not apply here. So I would kind of present both of those options to the patient. I would mention chemoimmunotherapy, but probably try to steer the patient away from it.
Dr. Brown?
Right, I agree with that. I think the deletion 11q is the strongest factor in this patient, driving toward the novel agents away from CIT even more than unmutated IGHV, because we know that they have not as poor outcome as 17p, but still a relatively poor outcome with chemoimmunotherapy. I do like the idea of time-limited therapy for a patient this young, but would just have a very detailed discussion with the patient about the venetoclax obinutuzumab versus BTK inhibitor options.
Dr. Kay?
I forgot to ask for a P53 mutation. Did you say
No
that?
mutation present. NGS
No,
panels.
the NGS panel, okay. Yeah, I like the idea of time-limited therapy too. This is a fit person, no significant medical history. The unmutated IGHV is a bit of a negative marker, but I certainly, if there isn't a clinical trial that's reasonable for this person, I would think that careful discussion with that individual about time limited, even with the risk of AML and MDS. And I've had some patients say, I just want
So
the,
when you say time limited, you mean FCR?
I'm sorry, yeah, CIT, yeah, 4.5 months and I'm done, and versus years and years on other therapies.
All right, Dr. Rai, anything to add?
No?
Okay.
I would probably offer this patient our ibrutinib FCR regimen off trial also. That's how I would offer the time-limited chemoimmunotherapy option.
All right.
I want to disagree. First I said no, but I think that there are convincing data from MD Anderson and from Germany that unmutated women would not have an advantage with FCR or chemoimmunotherapy. In my mind, this is a no-no for FCR, BR, anything. I think the best approach will be to obinutuzumab plus venetoclax. Limited time, 1 year.
So let me ask you, what would impact upon the decision of offering this person venetoclax obinutuzumab as a limited treatment duration versus continuous treatment with the BTK inhibitor?
Well, the high incidence of MDR negativity in this kind of a person is very strong evidence that A, financially it is better, clinically benefit-wise it is better. The only negative part is that this is a relatively new combination and the duration of follow-up is relatively short, which FCR people in mutated people have the advantage. That is, minimum of 13 years post FCR complete remission. But still, I think that this lady will have plenty of other opportunities should 1 year treatment with venetoclax and obinutuzumab seem to be short-lived.
Dr. Brown?
Right, so I like the venetoclax obinutuzumab option, but I do think one other piece of information we don't have might push more toward a BTK inhibitor. If she turned out to have an 11-centimeter mass on her abdominal CT that was managed to be asymptomatic, bulky adenopathy is associated with a lower CR rate with venetoclax, and so I think that that might push more toward BTK inhibitors that work better in nodal disease.
All right, I thank you all. So let's move on to the second case. Mrs. B is now a 65-year-old woman. Everything else is still the same. Dr. Davids?
So, 65 is kind of right on the borderline of these large data sets that we've just gotten from ibrutinib.
We'll make her 70.
Okay, so 70, now I'm thinking more in the frame of mind of the Alliance study and whether I would consider bendamustine and rituximab for this patient. I think here it's a little bit different in the sense that in the Alliance study there was no overall survival benefit even in the unmutated IGHV patients. So I think people could make the case that even for an unmutated patient, you could start with BR and then use ibrutinib afterwards, and the survival of the patient is not likely to be different. That's with relatively short follow-up. So, personally, this is again a situation where I'd try to steer the patient more toward a novel agent-based approach, especially in light of the 11q and the unmutated IGHV. And again, I think here we have the choice between ibrutinib or venetoclax obinutuzumab. I'm a little more comfortable recommending venetoclax obinutuzumab here, just because the patient seems more like the patient on the CLL14 trial. But I think either would be a good option.
Dr. K?
Yeah, at 7 years, it's 70 now, right?
Yes, 70.
70 years now, we're now dealing with increased rates, I believe, of potentially of hypertension and arrhythmias. And I would probably not be loving the option of CIT for this person either. And I do like the doublet combination if there's no clinical trial that's available that's advancing our knowledge. I think that's reasonable. So I think ibrutinib versus VO, ibrutinib rituximab. I don't know. I think those are all good options.
Dr. Rai?
I think that whatever has been said is right, but it is a little confusing. Do you say that this woman, in addition to CLL, has Waldenstrom?
No,
No, that was a
That was a
mistake in the
Slides.
slides.
that was a mistake.
That was the
So
wrong.
she should have a different name.
No, this is the first case patient with just now 70 years of age.
We're doing it to confuse.
Oh, I see, I see.
Would that impact upon your decision at all?
Okay.
It
Jen?
confused me too.
Oh, me? So, well, FCR is definitely out. And, especially with the 11q deletion, I think a BTK inhibitor or venetoclax obinutuzumab. The older the patient, the more I lean a little bit more toward trying to get acalabrutinib over ibrutinib based on the toxicity profiles and the cardiac tox.
So do you
And I
think,
will take issue with believing there's a real overall survival benefit in the ECOG trial based on 4 patients versus 1. Anyway.
so do you think there's a significant difference in the cardiac toxicities between acalabrutinib and ibrutinib?
You were saying it was different.
Jen?
What? I'm sorry.
Do you think there's a significant difference in cardiac toxicities between acalabrutinib and ibrutinib?
That's certainly been my clinical experience. We don't have a lot of data. We have a pooled series about 600 to 700 patients, which did have a several % AFib rate. And now we have a randomized trial presented last June where there were about 8 cases of AFib on the acala arm versus 5 on the control arm. It's hard to say too much about that. We're about to get a lot more randomized data at ASH. But my personal experience has certainly been that there's less cardiac toxicity.
I agree. I think that the numbers with the ACAL are smaller, but more than anecdotally, the relative incidence of AFib and bleeding are somewhat less, but no hard head-to-head comparison data are yet available.
Yeah, I think we all have our clinical experience, which has been similar with acalabrutinib, but this is a unique situation where we actually will have head-to-head data coming along with certain caveats. It's a study that I'm referring to the Elevate-RR study. It was not powered around safety endpoints. It was powered around a non-inferiority endpoint of PFS. But nonetheless, I think it'll be a useful comparison.
Any
Well, and we'll
comments
at least
on,
have randomized data against CIT more for acala well before we get the randomized data versus ibrutinib.
Right.
any comments on zanubrutinib and its likely side effect profile?
Well, Zan is supposed to be slightly less expensive and probably as effective as other BTKs, but low number of people treated. They say there are more people in China treated with that.
All right, so in a one-phrase answer, I want to hear ibrutinib versus ven anti-CD20 versus ven alone versus ibrutinib anti-CD20. Pick one. Matt?
For frontline for
this patient?
Yeah, probably ven-oben for this patient.
Dr. Rai?
I agree.
Neil?
I'm good with that.
Okay.
I'd take Van-Open also.
Yeah,
Okay.
if you're going for
Case 3. Mr. C.
case 3.
Are we okay? All right. Mr. C is a 49-year-old man who presents with a 1-year history of CLL and now requires therapy for Rye stage 3 disease and lymphadenopathy. His CLL profile demonstrates negative CD38, negative ZAP70, unmutated immunoglobulin gene, and a deletion 17p in 35% of the cells. What treatment recommendation do you recommend at this time? Dr. Brown?
So this is clearly driven by the deletion 17p for this patient. And in general, I think patients with TP53 malfunction are the ones who are likely to have the early transformation, early relapse with single-agent BTK inhibitors. So I would try very hard to get this patient on a combination clinical trial, ideally with a BTK inhibitor, a BCL2 inhibitor, if we had such a trial. and/or potentially try to get it paid for, although I haven't tried that in the frontline setting. So,
Conti?
It's again, I feel, a somewhat artificial case. Because if you had been fair to us, you would have said as to within 1 year, this lady or this man has gone from 13 gram, 14 gram hemoglobin to 9 something hemoglobin, or it has been like that already, always. Because there are some people who believe that just near diagnosis, a person who is free of B symptoms and has 17p deletion should not automatically be treated. But here we do not know. And in the course of 1 year from diagnosis, sufficient numbers of things are shown to us which would render treatment justifiable. And if treatment is needed, I would go with the 17p deletion and go with the BTK inhibitor or BCR inhibitor. So in that case, the treatment choices are clear, but we don't know whether in the course of 1 year there has been a clear-cut worsening of the patient.
Matt?
So yeah, certainly if there were a trial option available with combination novel agents, that would be my preference. I think outside of that, if I had to treat this patient with standard of care, I think the decision for me is still between ibrutinib or venetoclax obinutuzumab. I have to say, so far with the 1 year of time-limited therapy, specifically in the 17p subset, I'm not impressed that we're going to have durable response there, because there's been about 12% progression events in that arm of the study, and several of those have been patients with TP53 dysfunction. So, we have longer-term follow-up with ibrutinib in frontline 17p, admittedly in a pretty small cohort of patients from the NHLBI, but at least in that study, about 3/4 of patients are still progression-free at 5 years. And so this is a patient where I'd probably steer them toward ibrutinib. And then, I think that the second question there is a really tough one. We've probably all had patients in our clinic now who are in remission on ibrutinib with 17p and are kind of faced with this decision. Do they move on to allotransplant at this point because they're in a good remission, or do we wait until they start to progress and then try to do something else? We know that venetoclax in that setting probably has about a 67% response rate, our best guess based on the prospective data. So that's pretty good, but that still means 1/3 of the patients are not responding. And what do we do at that point if we can't get them into remission?
You jumped ahead, so you get to
Sorry.
pay the price.
Right.
So this patient was put on ibrutinib, actually remained on ibrutinib for 5 years, and actually obtained a very good response. All right. Do you send them now for an allogeneic transplant?
So I think that's the debate, and I have them usually meet with a transplanter and kind of learn about the process, and so that they can make an informed choice. I don't make a strong recommendation to move to allotransplant, particularly given what's happening now with CAR T therapy, and it's improving, and I think probably is eventually headed toward an approval in CLL. So I might try to keep this patient going with ibrutinib, hoping that if they do progress, I could switch to venetoclax, and that if that didn't work, that CAR T might be an option at that point.
Neil?
Yeah, I think those are wise comments. First of all, I do want to comment on something that you're showing a few times, and that is the prognostic markers. If I might comment just briefly on those?
I don't know. Do I want to hear it?
Probably not. But I'll say, if you want me to, I'll say it. Otherwise, we'll do it offline. But, okay, never mind that. So I, unlike Dr. Rai, I think I am getting the impression, although maybe I'm overplaying this, that this is somebody who presented to you and rapidly progressed hematologically. That the cytopenia has really changed, and he's 49 and having unmutated IgHV and the deletion of 70p is all pretty bad news. So I am in agreement that we need to get this individual to as negative a leukemic status as possible. I might, given what we know now about the triple combinations that have come from MD Anderson, I would have been tempted to think about that. I do think the CARs are going to move along pretty quickly. I was really impressed, although some people are skeptical, that the observations by Dave Maloney's group where ibrutinib underlying the CARs generates a lot of nice responses. So if I had this 49-year-old person, I was looking down the road thinking 10 years survivorship, I would have probably gone, knowing what I know now, I might have gone triple and then thought about CARs pretty quickly after the MRD negative status.
So are you suggesting doing a CAR T-cell treatment at MRD?
Well, I'm assuming that, well, let me back
Because
up.
currently we don't have a trial for that,
Well,
and the insurance won't.
I'm assuming that we have CARs that are going to come along. So I'm being this is the ideal world. So we need to take advantage of the graft versus leukemia effect. This is one leukemia that's extremely responsive to GVL. And I mean, John Gribben showed us that a long time ago. And remember the donor lymphocyte infusions? Those used to be pretty dramatic. And I think the CARs are going to be, so I'm being a bit idealistic and thinking, can I get this gentleman who's very young to a point where when the CARs are ready, if they weren't ready, maybe I would be considering a transplant if there was a match.
So
Really.
5 years MRD negative transplant match, you would go to allogeneic transplant?
I think it'd be in the conversation, yeah.
Jen?
So I would definitely have the conversation at the beginning around the initiation of therapy about the, expectations in the setting of 17P and the risk of earlier relapse, and then we only know we have venetoclax after that, and there's CAR T consolidation, there's allo consolidation. I think at this point, most people wouldn't choose to go rapidly to an allo without seeing how things go after starting on their BTK inhibitor, which I would, if I couldn't get my combination, I would favor the BTK inhibitor rather than the ven-open. After 5 years, is the patient really MRD negative? It's pretty unusual on
So
ibrutinib.
what I'm really trying to stimulate a discussion about is really the idea that, if you have a patient who's been out 5 years and is doing really well, do we think that that patient's risk for Richter's, though, is still as great as might be?
I don't think so. I was going to say I wouldn't send them at that point because I think they've somewhat passed the practical of early relapse, and so hopefully they'll be more salvageable when the time comes.
So that's ultimately the question is, so this person's made it out 5 years. Do we think that maybe they're free and clear? And if we're revisiting this patient now at year 2 and they're having an excellent response, but it's year 2, does that change your perspective? So does the tincture of time factor into your opinion?
It does definitely in my case.
Neil?
It's complicated. We don't have information on the natural history for ibrutinib only.
Except from the NHLBI study where there were several early transformations and then it's been more CLL progression later, but still 75% at 5 years. But very limited numbers, just a handful of patients.
So we agree essentially on that. What I guess I'm concerned about is if we are substratifying our patients in many ways, these prognostics, for example, we're doing things now we didn't do even 4 or 5 years ago. And the natural history for someone like this, where they're kind of a setup for some bad things, including clonal instability. I don't know about complex karyotype in this person, if you study that either, but if that were positive, I'd be thinking potentially explosive CLL cell. I think Tom Kipps coined this as a stealth cell. It likes to hide around and then come out when you least expect it with a new resistance mechanism. And he's only 49, 5 years later he's 54. That's pretty young to me. And I'm not trying to be facetious. And a conversation, don't you think, Jennifer, would have to
No, absolutely,
include,
even at the beginning.
Can we get you to a therapy which, to our knowledge right now, is the only curative therapy? I think you need to consider that.
Right, no,
Doctor?
absolutely. But a lot of the patients, they read some of the literature and they think that maybe new things are coming. We already have several great drugs, combinations are coming along, new things are coming on. They don't necessarily want to triage themselves early to transplant.
What about the PCYC1117 study? There's a definite tail on the curve, so we're now out beyond 5 years. I have 2 patients who are 17p deleted who haven't progressed or transformed, unlike everyone else who has progressed or transformed by now. Do they deserve the same treatment considerations, or have they declared themselves?
I mean, there is variety in 17p patients, right, based on TP53 mutational status, the burden of 17p deletion. Occasionally, we'll see a patient who's got mutated IGHV and 17p, and those patients can do very well. You know, this patient worries me because they have unmutated IGHV and a fairly high percentage of deletion 17p at the time of initial therapy. We don't know the TP53 mutation status here, but assuming it's probably mutated, as it is in most cases. So this is a patient who seems unlikely to have one of those durable benefits, but they might, and I think if they do, it does give me a little more confidence that they have some kind of perhaps even unmeasured, more indolent quality to their disease that gives me more confidence that we could potentially salvage them if they progressed.
Dr. Rai?
Rich, we have great confidence in you as an expert in CLL. So by being the moderator, you should not exclude yourself from opinion, because it would make it more interesting and believable to the audience if it became you also agreeing or disagreeing. As far as this patient is concerned, as far as I'm concerned, all the right things have already been said. Thank you.
All right, thank you. So one last question before the end of the session. Mr. C is a 62-year-old man diagnosed with CLL in 2008 when he was found to have an elevated white blood count on routine CBC. At that time, no lymphadenopathy, anemia, thrombocytopenia, or symptomatology. Prognostic markers are negative for CD38, ZAP70. He is trisomy 12, and he has an unmutated immunoglobulin heavy chain gene. NGS demonstrated no mutations in Notch, TP53, or SF3B1. Over the next 7 years, he demonstrates a slowly progressive course characterized by a white blood count up to 140,000, hemoglobin 10.5, and platelets of 110,000, significant lymphadenopathy prompting treatment with acalabrutinib on trial. Tolerated treatment well and demonstrated an excellent response, having achieved a hematologic and radiographic CR, but with slightly persistent slight persistence of disease in bone marrow biopsy and a nadir ALC of 3,000. At 36 months on treatment, he now demonstrates a rise in his absolute lymphocyte count to 5,500. Flow cytometry confirms that these lymphocytes are CLL cells, and the repeat prognostic markers now demonstrate a Notch1 mutation. He has been observed for 3 more months, and his ALC has remained stable at approximately 6,000. The patient remains on acalabrutinib given the absence of a formal progression as per trial, but then demonstrates what is a significant formal progression with a rise in the ALC to 9,000 and has 1 to 2 centimeter lymphadenopathy throughout the abdomen and pelvis, requiring discontinuation of the acalabrutinib. What do you want to do at this time? Dr. Brown?
Right, so the patient obviously has developed progressive disease on acalabrutinib. If you were allowed to keep him on acalabrutinib, I might have sat on it a bit longer, I have to say. It would be nice if we had the ability to test for BTK or PLC gamma 2 mutations, but we don't always have that ability. But it would be likely that the patient may have such a mutation, probably 75 or 80% likely. And so in the absence of a protocol, venetoclax would be the likely treatment of choice based on the data we have for about a 65% response rate in the post-BTK progressor setting. CR rate is lower, though, at about 9-10%. With trials of the next generation BTK inhibitors, I've been often doing that.
So are you suggesting that we initiate therapy at this point in time? Relapse patient, low tumor burden, formerly has progressed on a BTK inhibitor, and has a Notch inhibitor. Do we watch and wait as per standard, or do we treat early?
Well, right, so first of all, I would have actually kept the acalabrutinib on longer, is what I might have done. Although it's easier, a little easier with ibrutinib, especially if you know they have a BTK mutation, because ibrutinib still has some activity against the BTK mutation, where acalabrutinib has no activity against the BTK mutation. Now, so if you're forced to stop, that's a very difficult situation because in the setting of progressive disease, when you have to stop a BTK inhibitor, you can sometimes have massive flare. And so that is a concern
But none here.
in this There was no flare.
All right. Remember,
Okay,
we
then I
s-
would sit on it and
yeah.
I'd just watch.
Even with the notch mutation.
Yeah, notch mutations are a watch and worry situation for me. I don't think that we know that we have any intervention that changes their natural history, so it wouldn't change.
Neil?
Yeah, I think I would watch as well. I don't feel a compelling reason to treat this gentleman. I am a little concerned about the notch, and now, is this new this is new adenopathy?
New adenopathy.
Was not there before.
Not there before the patient achieves a radiographic CR. And the notch is also new, so this is
Yeah,
clonal
so-
evolution.
So it's very worrisome, and I'd be watching this person pretty carefully. I guess I'd also be thinking either ultimately very aggressive CLL or maybe even a Richter's ultimately, just because of the genetic milieu.
So how would you watch this patient?
Well, I guess there's no standard protocol unless I'm told otherwise, but given the new lymphadenopathy in the abdomen and in the pelvis and the notch, I might be thinking of more regular CTs.
How
Imaging.
frequently?
Not that frequently. I assume I'd be doing them every 3 to 6 months for a while. And if it was 2 consecutive intervals where I did not see significant changes, I probably would be happier for the patient and still watch.
Dr. Rai?
This is an interesting situation. As Sylvia said in response to my question, that discovery of Notch 1 is interesting, but it is not decisive therapeutic intervention suggesting. So this person, I would be cautious about is stopping ACAL, because as Jen suggests, that these people can blow up and you may not be able to revert that disease. So before you stop ACAL, you have to be sure that even though there is relatively non-bulky disease present or appearing, but you ought to be ready for more intensive therapeutic intervention. And if you look for BTK mutation for ACAL failure and you find it, then you are on a stronger ground to change to venetoclax.
Matt?
Yeah, I agree with everything that's been said. I mean, specifically to Neil's point, I think that I would also get some serial imaging here. Not too frequently. It would sort of depend on how the patient was doing otherwise from the perspective of the blood counts and symptomatology, but probably have a very low threshold here to get a PET CT scan if the patient had a rising LDH or developed any hint of B symptoms, because with the Notch mutation, I'm more worried about Richter syndrome here. And then, in terms of if this does end up being progressive CLL that requires therapy, a good trial candidate here because they're coming off a BTK inhibitor but not having explosive disease, so you have time to kind of line up a trial. Venetoclax combination trials, I think, are good ones to consider for a patient like this. We currently have a trial of duvelisib, the PI3 kinase inhibitor, with venetoclax. There's other studies going on with umbralisib and ublituximab and venetoclax, so that's the type of study that I might be looking for this type of patient.
So, but just to sum up that, this patient now has a new notch and doesn't have an IWCLL indication for treatment. Do you watch or wait, or do you treat?
Yeah, I watch and wait.
You watch and wait?
Yep.
Okay, and you're watch and wait by serial CT scans?
Well, serial visits, this might even be a patient I'm seeing monthly at this point, checking blood counts, physical exam, and then maybe a CAT scan in 3 to 6 months, or a PET scan if there's any hint of Richter's.
Okay.
Well,
So,
whatever has been said about CT scan, I go by physical examination and how the patient feels rather than a scheduled, rigid CT PET, and we tend to be starting to do the scans and PET scans little more frequently. And this kind of patient is one of those who makes you fall in the trap of overdoing. Same story with the bone marrow examination. That only if our therapy and the decision will change by whether you find X or Y with the bone marrow biopsy. So I think that by relegating those tests, we are going under the umbrella of delaying the decision.
So I'm going to address Conti's comment and open myself up to criticism and tell you what I would do in this situation, which is given the new Notch mutation and the clonal evolution and the fact that this person progressed on BTK inhibitor therapy, which I really believe are sort of all the markers of a bad case, and this being a relapse patient, I would initiate treatment with venetoclax at this time. Any comments on that?
I agree.
I don't think it's wrong. I mean, I think we don't know what the right answer is, but there's certainly no evidence that starting venetoclax early is going to be beneficial, just as there's no evidence that waiting is going to be beneficial. So I don't know. Yeah.
You could even monitor the allele fraction of the Notch mutation over time before treatment, and just to get a sense of whether that's changing. Right?
So the two things I just want to point out, one is, of course, venetoclax is a heck of a lot easier and safer to use with a low tumor burden. So sometimes I wonder if we set ourselves up for a difficult endeavor by waiting until these patients have large volumes of disease. And two, had this been a Notch mutation present at diagnosis, and now the patient 5 years later had it again at progression, it's still this ultimate question about why only half the Notch mutated patients progress. And so one of the questions I always have in the back of my mind is, once again, if this had been a person who's declared themselves as not being the type to develop a Richter's, whether or not that should change management. So that's actually the important question I think we may have to confront going forward.
To your first point, though, I think that's the argument for getting the interval CAT scan. In contrast to what Conti, I think with venetoclax specifically, it does really seem like with the bulky nodes, there's a couple of problems. One is the risk of TLS, but the other is that particularly those patients with very bulky disease over 10 centimeters do not have as good of a response in terms of depth of response, and that translates into a shorter progression-free survival. So I think if you got this CT scan 3 to 6 months later and it showed 4 to 5 centimeter lymph nodes, that patient may have a better outcome with venetoclax rather than waiting until there's enough progression on exam that the nodes are 10 centimeters at that point.
But I would have given the treatment at the 1 to 2 centimeter mark and not even have needed that.
Right, but we don't have any evidence that you'll selectively eliminate the Notch clone, or even that you'll eliminate it together with the other clones. You may actually select it and enrich it.
But, the question
We just don't know.
venetoclax now versus venetoclax later wouldn't impact upon that either, right?
Well, unless the other microenvironmental lower risk clones are inhibiting the space the Notch clone can fill, and then by clearing them out, you make more space for the adverse clone, like an additional clonal selection process.
We have a question?
About the stopping the ibrutinib or acalabrutinib. I had a patient who had bad pneumonia and had to be hospitalized multiple of times because of pneumonia. And I was really worried, what is the safest duration of interrupting the treatment and how to monitor him. And the second question is in patients where a decision is made to switch to venetoclax and they are barely held with ibrutinib, what is the recommendation of the switching? Should they be in a combination till you wrap up the dose to the therapeutic dose and then stop the ibrutinib?
So I tried to duck the second question by having this patient on a clinical trial where there couldn't be a question of continuing the BTK inhibitor. But who wants to address the first question?
I can start, I guess. And I think the first question, to me, it depends a lot on where the patient is in their disease course. Is this a patient who just started on ibrutinib a month ago and still has a big disease burden? And there, I'm anxious about holding it. You know, I may still hold it during an infection, but I'm trying to get them back on as quickly and safely as I can. You know, if it's a patient who's been on ibrutinib for 2 years and is in a very deep partial remission and their blood counts are okay, you know, there I'm comfortable holding the ibrutinib for longer. I've had patients where I've had to take them off ibrutinib permanently for atrial fibrillation, for example, and those are patients who sometimes can actually do very well and stay in a partial remission for months or even a couple of years. So I think it depends on where the patient is in their course.
All right, second question.
Rick, for one of the few times I agree with you, but that's neither here nor there. I do take exception, though, on doing serial CAT scans. You know, in the lymphoma world, we found out that doing serial CAT scans after a patient was in remission really didn't pay. And in those patients who have follicular lymphoma, we do them less and less frequently because we know you do a PET scan at one certain point, the next day the patient could have a relapse, or in this case, would have transformation. What do you gain by doing all of these frequent serial CAT scans? Do you have any, or PET scans more importantly, do you have any data that the early application of treatment is going to make an iota of difference before the patient becomes symptomatic, or before the LDH rises, or before the patient tells you he's sick?
There is no data. There is a great suspicion that early diagnosis of Richter's is probably very different than, at least there would be in my mind, than following most lymphoma patients, but I'm not a lymphoma expert. I'm also influenced a lot in my patient cohort by how smart these patients are. And I have to say, Mort, to a certain extent, I am confronted with, what are you going to do about this new node? And how are you going to take care of me? And if I tell them physical exam, I have had patients respond well, so you mean you can tell what's going on in my belly. So there is a little bit of that conversation going on. I would have to say, unfortunately, not, well, fortunately, Richter's is rare. And it's a devil to deal with, especially if they're clonally related. So our practice is more inclined to try to pick it up early and to get a patient on treatment early, but you're right, there is no solid evidence that earlier treatment makes a difference. The only thing I would argue about is I'd rather start treating them with tough therapies while they're fitter, which to me means earlier. Admittedly, there aren't a lot of clinical trials. We desperately need, I think, a national Richter's organization with, it's a rare disease, but we need to come together and figure out how to diagnose, when should we, you know, how should we be following up the high-risk patients, and when should we be initiating therapy? You know, does picking it up early make a difference? We don't know those. But those are critical questions in my mind.
Let me challenge you even further. How many patients do you get that come down with Richter's who aren't symptomatic? In other words, we found that when you relapse from large cell lymphoma, these patients are usually symptomatic. The patient tells you something, or you pick it up, and we don't find the disease that much earlier. And so what I'm wondering is, why do them on a, how often would you do these PET scans, Neil?
Not very often now.
I'm glad I convinced you.
I was only proposing to, well, I think a compromise between what Dr. Rice, what Kanti said and what I said, you know, I wouldn't be doing it every 3 months. I think physical exams are absolutely important. And if in this patient, case number 4, if there was now a node palpable in the neck that might spur me on to doing imaging, you could marry the two. I don't think there's a, as Matt was saying, I don't think there's a perfect plan here, but I think imaging comes into play somewhere, and I don't know that it would be when they're floridly ill. I would think it might be better to do it earlier.
All right, with that, I'm going to thank the members of the panel.